Welcome to AETCM, the emergency medicine channel. Today, let us discuss about management of chronic liver disease in emergency room. We know that chronic liver disease is a very common condition, mostly because of chronic alcoholism. There are other reasons also can produce chronic liver disease. It can be due to hepatitis B induced chronic liver disease, hepatitis C induced chronic liver disease, Wilson disease. So many are fatty non-alcoholic steatohepatitis, NASH induced chronic liver disease. Whatever it is, the ultimately when the liver is shrunken and when it produces pressure symptoms and functional defects of liver, there will be a lot of clinical findings, and patient may come with various type of problem. It can be fluid overloaded condition, it can be breathing difficulty, it can be pneumonia, infections. So many reasons patient come to emergency room. So if we know the basics of the disease, it will be very easy for you. Now, once there is fluid accumulate in the body, you can see here fluid is accumulated in the body, that is called as ascites. So in cirrhosis, patient develops portal hypertension. That will produce splanchnic arterial dilatation. So when there is arterial dilatation, so when an artery is supplying, for example, your kidney, so kidney is getting supplied blood supply from the artery. When the artery dilates, actually the pressure will decrease in the artery and the supply will reduce. Okay, so the internal organ, especially inside the abdomen, can suffer from reduced blood supply. So effective arterial volume will come down. Then that when the kidneys are not getting adequate blood supply, the renin angiotensin aldosterone system will be activated. So when the kidneys are not getting adequate blood supply, the kidney will activate renin angiotensin aldosterone axis. So that will produce secondary hyperaldosteronism. That is very important. So secondary hyperaldosteronism tried to retain water and sodium. That sometimes it can produce normalization of circulation, but after some time, initially it will produce normalization of circulation, after some time sodium will increase. So retention of sodium, retention of water, and renal vasoconstriction. Okay, so all these things ultimately produces problem like patient can have ascites, dilutional hyponatremia, and hepatorenal syndrome. Hepatorenal syndrome means because of this reduction in the splanchnic circulation, kidneys are not getting adequate blood, and you can see the kidneys are getting damaged. It is not a permanent damage, it is a reversible damage, but normally it will not reverse because it's a terminal process of the liver disease. So creatinine will be elevated, urine albumin will be more. So these are the problems in hepatorenal syndrome. Slowly patient develops chronic kidney disease also, but actually there is no pathology inside the kidney. It is all due to the selective hypoperfusion of the kidneys. So patient can develop ascites, hyponatremia, and elevated creatinine levels. Now, when we treat chronic liver disease, we always see what is the reason. So, when we see a patient with ascites, actually it is when we see a patient with ascites, we can diagnose the reason for ascites by checking the serum ascites albumin gradient, that is SAG. So, depending on the SAG value, so you can calculate here albumin concentration of serum minus albumin concentration of ascitic fluid. So, you can calculate this SAG. Once you diagnose SAG, whether it is more than 1.1 gram per deciliter or less than 1.1 gram per deciliter, you can see what is the reason for the ascites. Okay, sometimes the reason can be due to chronic liver disease, that is cirrhosis, but there are a lot of other causes also there. So depending on the serum protein, ascitic protein, there are multiple reasons, and SAG less than 1.1, there are other reasons. We are not going to all these details now, but SAG is a very important investigation which will tell you what is the reason for ascites, what is the probable reason for ascites. But in many cases, who is having chronic liver disease, we know that already chronic liver disease by ultrasound, LFT and all. So cirrhosis normally produces ascites. So in a known case, we don't depend on SAG, but in an unknown case, as an initial workup, we can depend on this SAG value. Now, once you diagnose liver cirrhosis with ascites or volume overload, we will be admitting this patient depending on the clinical scenario, whether to ICU or sometimes to the ward, whatever it is, but we have to initiate the treatment initially itself. So mobilization should be done. Most of the diseases, early mobilization increases the recovery or fasten the recovery. So here mobilization like any edema can be improved with mobilization, and there are some other ways also we can reduce the fluid. So maximum mobilization is important. Next thing is volume restriction. So intake output chart should be strictly maintained, and 1 liter per day should be the intake. It should be restricted. Second thing is salt restriction, 2 gram. You have to restrict the salt to 2 gram. That is very, very important. Normal Indian diet may contain 6 to 8 grams of salt every day, but we have to restrict it now to 2 grams. If you give more salt, what happens is salt will try to increase the volume. Okay, try to retain water. That will produce ascites, increased ascites. So here also more fluid, increased volume, and it increases the ascites. Okay, so never try to give more salt or more fluid. Even if hyponatremia is there, you should remember that hyponatremia is due to dilutional hyponatremia. Now dietary protein restriction is very important. Those who are having hepatic encephalopathy with chronic liver disease, animal based protein should be restricted. We can still give vegetable based protein if the patient is not having hepatic encephalopathy. In hepatic encephalopathy, we have to restrict both types of protein, and once the patient is stabilized from hepatic encephalopathy, you can start vegetable based protein. Now next one is diuretics. Diuretics are, we know that any volume overload condition, diuretics are very important. The most important diuretics will be furosemide, Lasix. So in emergency room, we always give injection Lasix 40 milligram or 80 milligram, and that removes some amount of fluid. So even if the BP is low, suppose the BP is 100 by 80, you may think that whether we can give Lasix or not. If you are giving Lasix as an IV push, then that reduces BP. That is very important. But if you are giving a slow infusion like this for a long time, so same milligram, so 40 milligram is given as IV push, that may reduce the BP. But 40 milligram over 6 hours or 7 hours or like that, if you give more time, the BP reduction will not be there. So that only removes the water. So water will be removed, but BP will be maintained. Okay. So you can give still as an infusion if the BP is low. But this is a very good, Lasix is a very good diuretic, but there are some issues for that. It can remove the potassium also. Lasix also removes the potassium. So that is very important. We don't want that to occur because hypokalemia is one of the important reasons for precipitation of hepatic encephalopathy. So we always try to add spironolactone. So spironolactone with Lasix. So advantage of spironolactone is it's an aldosterone antagonist. So we have already seen that in chronic liver disease, secondary hyperaldosteronism retains more water. So spironolactone should be given along with Lasix because spironolactone is an aldosterone antagonist. And another important thing is it's a potassium sparing diuretic. So hypokalemia can be prevented. So these are the two important reasons we are adding aldosterone to the regime. Okay. Now chronic treatment can sometimes produce gynecomastia. There are some alternative drugs for that that can be tried. Now in a patient who is having ascites and pedal edema, every day your target weight loss should be 1 gram per kg. That much like you can increase the dose to up to 400 plus 150 milligram can be increased. If only ascites or only pedal edema is there, the weight loss target should be 0.5 kg per day. So that is very, very important. Now, if you want to remove more fluid, you can go for large volume paracentesis or a TIPS therapy that we'll discuss afterwards. So, large volume paracentesis means this is ascites. So, you remove 5 liter, more than 5 liters of fluid. The problem for this is when you are removing more than 5 liters, you can see the blood vessel. This is, for example, this is a blood vessel. If you are suddenly removing the water from the ascites, from blood vessel, the water can shift to this third space. So there will be further intravascular collapse. So to avoid that, we have to give albumin, injection albumin and give and remove the fluid. So give albumin and remove the volume from the abdomen. That is called as large volume paracentesis. But albumin, you know that albumin is very costly, so it is very difficult to give albumin all the time. And albumin, even if you give 1 or 2 pints, it will be removed from the body immediately because liver is not producing any more albumin. Now, bleeding tendency is another important problem. You can see the INR will be elevated in most of the liver disease because one of the function of liver is maintain our bleeding, proteins, okay, coagulation proteins. So, if they are not produced properly, patient can have bleeding tendency, ecchymosis, and INR will be elevated. Normally international normalized ratio and patient blood ratio will be 1:1. Okay, but if it is more than INR more than 1.5 in any patient who is previously stable, that is an abnormal value. But in chronic liver disease, you can see it will be always more than 1.5. It may be 2 or 3 or 4 like that. So depending on the bleeding tendency only we treat this patient. And many books says that you can give vitamin K in injection, but in chronic liver disease as such vitamin K deficiency is not there. But in a patient who is having obstructive jaundice, vitamin K will be very helpful. However, in many of our patients, we try vitamin K injection 10 milligram IV for 3 days, thinking that there may be some deficiency of vitamin K in that type of patients. But actual vitamin K deficiency will be in obstructive jaundice because fat soluble vitamins will not be absorbed in the obstructive jaundice. But here also we try to maintain vitamin K in a normal limit. Now, if the PTINR is elevated and if you want to treat the patient, you have to go for fresh frozen plasma. So that can be tried if there is a bleeding tendency. Blood transfusion should be tried in a severe case of anemia or severe bleeding tendency. But only one problem is we always try to keep the patient's HB somewhere around 8, because any type of bleeding tendency, especially when there is a bleeding parameters are abnormal, if you over perfuse the body with blood, the pressure in the blood vessels will increase and the bleeding can become more. So we have to be very careful. No need to overcorrect the anemia. Just maintain the HP level somewhere around 8 to 9. And along with blood transfusion, you have to give fresh frozen plasma and platelet. So we know that all these things will be deficient in this type of patients. So chronic liver disease patient, they can have anemia, they can have bleeding tendency, they can have thrombocytopenia. It is something like trauma patient. You may have to give all blood components in that patient or give a fresh blood to the patient. That is also okay. Now next one is if there is a bleeding, what to do? You can give pantoprazole. Pantoprazole given because when there is a bleeding in the stomach, especially like an ulcer bleed. So ulcer bleed, you can see here the blood is coming out from the ulcer and there will be some clot formation here to prevent the bleeding. What happens if the acid in the stomach is increasing? Acid is increasing means this clot will be lysed. To prevent that, we can give a drug which can suppress the acid overproduction, that is pantoprazole. So pantoprazole can be given, pantoprazole or any PPI can be given as IV stat BD or it can even be given as an infusion. Both have same properties. So whether you give infusion protocol or IV protocol, both are almost similar. Next one is octreotide. It has got a splanchnic vaso. We have already seen that splanchnic vasodilatation. It has got splanchnic vaso constriction. Octreotide 100 gram bolus then 50 gram hourly infusion. Otherwise, you can give stomatostatin 250 milligram bolus then 250 gram hourly infusion. So that can be given. So endoscopic varicose ligation is another option. If you have a gastro center, you can send the patient for EVL and sclerotherapy. Sclerotherapy means a sclerosing agent is injected and bleeding will be arrested. Endoscopic EVL dilation means this is a blood vessel which is bleeding. They put a ligation here. So that blood vessel will be blocked. Now, beta blockers are another important drug which can reduce the portal hypertension. It is not an acute drug. Never try to give injection beta blocker. It produces slow action. Previously, we used to give propranolol, but current guidelines say that carvedilol is a better drug than propranolol. But whatever it is, both will have similar, almost similar activity. Carvedilol can be started for this type of patients. You can give carvedilol 12.5 milligram BD. So that is a current recommendation. Previous recommendation was propranolol 20 milligram BD or slightly reduce the dose slowly. Both has got similar activities. Current guidelines says that carvedilol is better than propranolol. Now nitrates, if you are not able to give beta blocker due to any reason, nitrates also can be tried. But nitrates are not as good as beta blockers. Another important drug is lactulose, because lactulose is not a drug which can prevent the bleeding, but it is used to prevent the hepatic encephalopathy. You know that in our intestine or abdomen there are a lot of ammonia producing bacteria. That is very important. This lactulose is a drug which can produce loose stools, and it can be it is a poorly absorbable drug. It will not, even if it is you can taste it, it is sugar solution, but it will not be absorbed. So ammonia producing bacteria can be cleared from the stomach because there are multiple action. It reduces the pH of the intestine so that it can reduce the bacterial overgrowth. It removes the stools from the stomach so that the accumulation of bacteria will not be there. So two reasons it clears the bowel. That is the most important thing. Now dose, you can give either syrup 30 to 60 ml every hour until the diarrhea occurs. Okay, that is very important. Patient passes 2 to 4 soft stools per day, or you can even give lactose retention enema. Some patients who are not able to take any oral drugs, and if they don't have a Ryle's tube, you can go for lactose retention enema. Another drug which is antibiotic, which suppose you are suspecting spontaneous bacterial peritonitis, injection ceftriaxone is a very good drug because it acts against gram-negative organism. The most common organism which produces SBP is E. coli. It's a gram-negative organism. So ceftriaxone can be given 1 to 2 gram IVOD. Should avoid sedatives because liver is damaged. Sedatives, if you give, there will be over accumulation of these sedatives in our body, and patient can develop altered behavior, coma and all. So we should avoid sedatives. NSAIDs anyway, because liver is damaged, NSAIDs should not be given. High protein should not be given. Hypovolemia should be avoided. Hypervolemia should be also be avoided. Hypokalemia is very important because potassium hypokalemia can precipitate hepatic encephalopathy. Hyponatremia, you can get it in volume overloaded conditions, so we have to be very careful when we are treating hyponatremia. If you give 3% saline in a patient who is having hyponatremia due to volume overload, then it is going to deteriorate the situation. Many patients can have osteoporosis. We can give by bisphosphonate, calcium and all. Large volume ascites, we have already discussed. Give albumin along with large volume ascites tapping. Transjugular intrahepatic portosystemic shunt can be given to reduce the portal pressure in many patients who is having portal hypertension. Now sedation, anesthesia, anticonvulsant, it's a big topic. We cannot discuss it now. Avoid long-acting drugs like diazepam and all. Short-acting drugs can be selected if the patient is like agitated. You can go for midazolam. It's a very short-acting drug. Then other drugs like Fentanyl can be given. Propofol. Paracetamol should be normal course. We avoid paracetamol because it can be dangerous in a chronic liver patient. The dose should be reduced. In seizure, we always give levetiracetam because phenytoin, phenobarbital, all these things are contraindicated in chronic liver disease. You can go for levetiracetam, 500 milligram TID. Now, we have already discussed about antibiotics. Previously, there was a concept that gut sterilization with metronidazole. But metronidazole is an absorbable antibiotic. Neomycin also were tried previously. Now, rifaximin is the choice. This is a non-absorbable antibiotic. You can give 400 milligram TID. There is a dose. Then preparation of L-ornithine, L-aspartate that can be given in patients with acute liver injury. These are all add-on drugs. So if you see in a nutshell, if you are seeing the regular treatment, ascites, it is we already discussed that diuretics, carvedilol, and other supportive therapy. Refractory ascites, we can give one important drug is clonidine or midodrine. We can give midodrine because it's a very safe drug that can be tried. Terlipressin, intravenous terlipressin is another important drug. We have to, if the patient is in ICU, we can try this to reduce the portal pressure. Large volume paracentesis and tips we already discussed. So these are the common treatment for intractable ascites or refractory ascites. So we have discussed about one important condition, that is chronic liver disease management, especially in your ICU, emergency ICU. Patient come with various problems, like a patient can have respiratory infection, urinary tract infection, hyponatremia, hypokalemia, altered behavior, encephalitis, hepatic encephalopathy. We cannot discuss all these things together, but we have discussed a general treatment for chronic liver disease patient coming to emergency room. Depending on the clinical scenario, why the patient is admitted to hospital, that also we have to treat sometimes. Thank you.